Welcome to the webinar, Delivering Bad News. Hi, I'm Barbara Lewis, the Managing Editor for DocCom, which is an online communication skills learning system for medical schools, residency, PA, and NP programs, and hospitals, now that DocCom offers over 40 CME credits. Joining me today is Dr. Timothy Quill from the Palliative Care Program at the University of Rochester Medical Center. And welcome, Dr. Quill.
Thanks. Glad to be here.
Well, we're honored to have you. This is such an important subject. Do you want to tell us a little bit about your background?
Well, I was trained as a primary care general internist. I've done a lot of work in primary care and in hospitals as sort of what would be considered a hospitalist. And then probably the last 25 years, I worked primarily in palliative care, which is taking care of sicker end of the spectrum patients. That's what I do exclusively now.
And you have quite a resume here, authoring over 150 articles and several books. And I like the last bullet point here that your case was heard by the U.S. Supreme Court.
Yeah, I really write about what general physicians and clinicians face on a daily basis. So I'm more of a describer of what we all try to do than a real researcher. But I've done a lot of that.
Great. So this webinar is going to last about 30 minutes. The recording and the PowerPoint will be available on the DocCom website very shortly. If you have any questions, you can type them into the chat box, which is located in the panel. And if we don't have a chance to get to your question during the webinar, we'll respond afterwards. So first, as we get started here, Tim, can you tell us a definition of delivering bad news, or bad news, I should say?
Well, bad news is generally something that really changes a person's view of the future, of who they are as a person in some sense, and then how their future is going to unfold. So it may depend on the meaning attached to that news by each individual patient. So for one patient, the diagnosis of hypertension may be devastating, and because they had a family member who had a stroke, and hypertension was the beginning of that whole experience for them. And for another patient, hypertension would be very little. There are clearly some diagnoses, though, big new diagnoses of cancer or major illnesses that I think would be experienced as bad news by just about everybody. But there is the potential that doctors and clinicians may see what patients see as bad news, not as bad news, and so there may have to be some reconciliation in that sense. So again, why is it difficult to deliver bad news? Well, most clinicians have never been trained to deliver bad news. You know, I went to Rochester where communication was a big part of the curriculum, so we had some training in this, but I think a lot of folks have never been trained. And again, what often is associated with bad news is strong emotion. So again, there are a whole set of emotion management skills that maybe people are less comfortable with than they are in information. We also don't want to hurt patients. We want to protect it. We want to ease the news. So we might soften the language. We might soften the prognosis because we don't want to hurt people. So and in doing so, there may be some short-term gains, but in the long run, I think we undermine the sense of honesty that really needs to underlie the doctor-patient relationship. But we do this for good motivation because we don't want to hurt people, but that is something I think we have to figure out how to get over. So there's a basic structure to this kind of communication. It's actually a pretty general structure for lots of communication skills, and I'll give a quick overview on this slide. One is that you pay attention to how you're getting things started at the beginning, and then using the ask, tell, ask technique, which has gotten popularized recently, which I do think is a wonderful way of keeping clinicians from talking too much, really, where you give a little bit of information at a time. I use a lot of wish statements, and I'll explain a little bit more what I mean by that, because it's a way of expressing your compassion for patients, and also a lot of response to emotion, because bad news usually is associated with emotional responses by the patient. And then sometimes we don't really know what's going on, so instead of guessing, we really try to have the patient expand on that before we really get too deeply into trying to resolve things. Again, the whole notion of doctors interrupting patients in 21 seconds and then kind of doing our own thing this is sort of the opposite of that, is when you don't really know what's going on, you try to get the patient to really tell you more about it. And then finally, if we are moving into a new zone with bad news, we need to involve others, family members and other medical providers. So we're going to unpack that now a little bit. One is when you are going to have to give bad news, particularly if it's in a domain that you're not particularly familiar with. So as a generalist, I know a little about a lot of stuff. I know a lot about some stuff, but if I'm getting into an unusual diagnosis that I'm not familiar with, I really need to do some confirming of the facts and sort of planning. I'm also going to need to choose the right setting. Again, if it's an everyday kind of bad news, the setting is going to be pretty common. It's going to be my office. But if it's going to be a bigger kind of bad news, and we're going to have a lot of people present, we're going to have to plan for that a little bit. Who should be present? Should family members be there? Are there other clinicians besides me that need to be there? And then before we go in, particularly if it's one of these bigger meetings when there are a lot of people there, we really need to kind of, at least for a few minutes, talk about what's our agenda. Is there anything that we're not in agreement about amongst us, and what do we know about the family? Who's going to lead the meeting? So these things need to all be more or less settled before you go in. And then again, in these bigger meetings, who's going to be the lead communicator? That should be decided. So that getting started, the lead communicator would introduce him or herself, explain what their role is in the care, and they're going to ask basically everybody in the room to introduce themselves. So every family member there, what's their relationship to the patient, who is the patient, and then all the clinical team members should all be introduced, at least in terms of who they are and what team they're a member of. And then some basic interviewing. How are they feeling right now? So if the patient is terrified or if they're in severe pain, we're going to deal with that now before we get into any of this new interaction, before we get into new realm. Or if the patient is confused, you want to know that before you start providing a lot of new information. And once you settle those things, then you're going to begin to set the agenda. We'd like to talk with you about the results of your tests. I want to make sure that if they have any other things on their mind for that day, I want to make sure I know that up front so that I don't plow forward with my agenda without addressing theirs. So again, my general rule, and actually the places where I make some mistakes in this process, is when I don't have the patient and family talk first. So again, I would like to know how they see the patient is doing, what have they been told so far, and if I were a card player, I would like to know something about what they're coming in with, what's on their mind before I tell them really what's on my mind. And I generally try to make contact with all core family members in the room before getting started with the bad news. So we'll hear from the patient, the spouse, the parent, the child, just to be sure we're more or less on the same page. And if there are differences in opinion before we're getting started, I'd like to know something about that, see if they can be reconciled. And then before I'm going to deliver the bad news, I really want to establish readiness. So again, would it be helpful for us to share what we learned so far? Are you ready to talk about the results of the biopsy? And sometimes this might be considered, and put this in quotes, foreplay, that it's sort of getting people ready. It's foreboding, because generally if it was really good news, you probably wouldn't do a lot of this stuff. You wouldn't be holding back. So they're watching you like a hawk, particularly if they're anticipating it might be something potentially bad, and seeing how you look. And this is sort of them getting prepared. And then once you begin to deliver it, so are they ready to talk about it? They say yes, and I'm going to give information in very small amounts, building on what they already know. And so I'm going to tell them whatever it is that I have to say, and then I'm going to check in with them to see if they understand and ask if they would like to hear more. So if you want to hit the next slide. So if I look at the errors that we make I observe a lot of conversations like this, is that we tend to give way too much information all at once. So if you find yourself in the telling part of this and you're just giving news, all the details that you know, just make yourself stop and then ask what's been heard and ask them to repeat back what you said already. So you really want to have this be a give and take. Some people will need to hear a lot of information, but others are going to be overwhelmed with emotion. And if you're continuing to give information and they're overwhelmed with emotion, they're not going to be hearing much. So if it is emotion, if they start to tear, they start to cry, they start to feel that their mind is a blur, telling more information just needs to not happen at that point, because it's not going to permeate, and you need to shift into emotion management strategies. Now, if you run into an encounter, sometimes it's all questions and no emotion. So people are peppering you with questions, wanting to know everything possible about their disease. And you're going to try using this back and forth, ask, tell, ask, to give as much of that information as they really need. But then you're going to set the stage. You know, when you go home, you may have some strong emotions to this in response to this news. And I'm glad to talk with you about those, and you can give me a call if they're really strong. So you're setting the expectation that it's pretty normal to have emotion. It's to be expected, and they might anticipate that. So then and if emotion, or if and when emotion happens, you're going to shift into some what might be considered emotion management skills. Again, strong emotions are, if you think back in your own personal history of times where either you or someone you love or care about has gotten some really bad news, this is a pretty emotional time. And again, most of us as clinicians are much more comfortable with information than we are with emotion. But basic emotion management skills are actually pretty easy to learn and be applied. A lot of them can be done just as a skill rather than having to be the most empathic person in the universe to do this. So I can do a lot of emotion management skills on days that I don't have a lot of emotional juice or empathy. And yet some of these are simply skill. And responding to emotion in the long run is actually quite time efficient, because if you're trying to walk around it or plow through it, generally you're going to have to go back and revisit the information that you've been trying to impart because it's not getting through, and then you may have to pick up the pieces of the emotion as well.
And DocCom actually has a module on dealing with strong emotions.
Yep. And so there are a bunch of different acronyms for doing this. This is one that I like to use just because it's very simple. So if somebody, if I'm giving bad news and somebody starts to cry, I might say, you know, I can acknowledge that they're crying. This is not rocket science here. So you can say, you seem sad or upset. If they're angry, you can say, you seem angry. And then we have this tremendous power as clinicians to make people feel more normal. So we can legitimize emotion. So anybody in your shoes would feel whatever the emotion is: upset, sad, angry, frightened. And if we don't quite get it, you know, so I've given somebody, again, the diagnosis of hypertension, and they seem devastated about that. I'm gonna try to get them to tell me more about that. Tell me more about why this is devastating for you, because I'm not sure that I understand it. And so I'll do tell me more and tell me more. I'll repeat that a lot of times until I start to understand it. So they tell me about their dad who had a stroke after having hypertension, and then all of a sudden I do get it. And once I do get it, then I can empathize, because I now understand why that would be frightening, and I can imagine that I would be frightened if I had that history too. So again, that gives you this opportunity to be with the patient in that way. And then support is part of this as well. We're going to work through this together. So again, emotion management skills just are part and parcel of what we need to do. But again, I can do, sure, I empathize. I may not be able to do if I'm I don't have a lot of emotional reserve, but the others parts I can do because they're really basically a skill. And actually, once I do those things, sometimes that awakens my empathy. And then I wish statements. So I discovered I wish statements pretty early on in my career, and they are, I think, very effective, particularly around bad news situations. So these are things that I can say that I genuinely wish. I wish I had better news for you. I wish medicine was more powerful than it is. I wish we had more options than we do. I wish things had turned out better. And I really do wish those things. And when I say these things, people know in a certain way that I understand what they're going through. But wish statements are interesting statements in that they reframe what is hoped for as a wish. So it also, without specifically saying it, it acknowledges that what is hoped for is not likely to happen. It's a wish. It's not something I expect to happen. So it identifies what patients may be unrealistically hoping for, but puts it in a more realistic frame. And then again, if you are doing wish statements, often that opens the door to emotion, and then you're going to be able to acknowledge that and legitimize it and explore it and empathize. And then again, after people have had a chance to express their emotion, you may go back to some of the more information exchange, the planning for what comes next. And then again, when you tell me more as a strategy for deepening understanding, so when I don't really get why someone is reacting in a certain way or what they're confused about, I'm just going to have them tell me more about the most upsetting part, the most worrying part. If you're courageous enough, if they're getting angry, tell me more about the part that made you the most angry, because oftentimes if we're able to dive into this with patients and it often opens a door to really understanding them as human beings, and also pulls you together rather than tears you apart. So the tell me more, I think, is a really great strategy when you don't exactly know what's going on. Rather than guessing and rather than plowing through, you go to try to deepen the understanding of where you are. So again, this can be the basis of subsequent empathic statements. Now I really have a sense of why this is so distressing for you. I can imagine I would react similarly in your shoes. It can be followed by a recommitment to work it through with them. We'll work hard to find an approach that makes sense. We'll help you sort out the next steps. And again, I'm often doing tell me more until I really understand, and it just deepens a part of the story. Now, I don't do this all the time. I really only do it when I really want to know what it is that in a certain domain. So it's tell me more about something that I don't quite understand. And then finally, we're going to involve family members. So if key family members were not there, we have to make a plan for informing them. How are we going to talk to your children about this, your spouse, whoever it is that is not there. If this has been a family meeting where you've given the bad news and then you have to go talk to the patient about it, who do you think should go with us when we talk to the patient or talk to the patient's spouse or the parent? And if family members request that someone not be told, either family members or the patient, him or herself, we're going to really try to understand that. So tell me more about that until you really, until it really makes sense or not. In general, not telling people is not a good idea unless there's a really strong idea for it, because most of the time they know anyway. It just becomes something they don't talk about. And again, if you're members of a clinical team, it's in the hospital, for example, and you've really delivered some serious bad news, it's good to talk to the bedside nursing staff so that they know what's been told, so that when we walk in and see the patient crying, they're able to respond to that. If other clinical teams are involved, again, in our hospital, certainly, and probably yours, there's a lot of players, and we want to be sure that we're all on the same page about knowing about what's going on. And then if we do have differences of opinion between clinical teams about approaches or strategies, we want to try to talk about that away from the patient and family first, and then figure out how best to share that with the patient and family. So finally, after you've done this, make a plan for follow-up. What are the next steps? I'd like you to see a cancer specialist. Why don't we meet again in a couple of days? If you're in the hospital, I'm going to be coming back at such and such a time tomorrow. You're going to be suggesting that they may have lots of questions and to write them down, and we'll try to deal with them next time. Make sure that the patient has adequate support. So if you've given bad news and the patient is by him or herself, can I call somebody? Where are you going to go from here? And reassure the patient that they're not going to be abandoned. So we're going to work together to find the best path. If a patient says, I'm thinking I'm going to take the bridge, after giving bad news, and there are case reports of this occurring, we want to take that kind of thing very seriously and make sure we address their safety and help them call somebody and make sure somebody's going to be with them. So now we're going to walk through a quick case presentation just to give a sense of what this is like. This is a real case that occurred, a 60-year-old man who had symptoms of peptic ulcer disease and was found on biopsy to have gastric cancer. He had been told that the biopsy needed to be done because there was a tiny chance that it was gastric cancer, but it was not felt to be very likely, and that chance was minimized in the pretest counseling. The biopsy did show gastric adenocarcinoma, and you have to give them the bad news. In this case, I had to give them the bad news. So how do you get prepared? I think that the first step in that is that these kinds of diagnoses, particularly surprising diagnoses in people previously healthy, we as clinicians have strong reactions to them. So we may be having to go through our own grieving, our own preparation. I often will talk to my own staff, my colleagues, about my own reactions, so I try to work through some of that before I go in to meet with the patient. And then I'm going to have to learn about the medical facts. Again, the medical facts of gastric adenocarcinoma are not very pretty. Cure is very unlikely. It's unusual to diagnose before it's spread, so 5-year survival looks bad. And the next steps are going to be CAT scan over the abdomen and probably surgical and medical oncology consultations. So I need to know all that stuff going in. So we'll skip this. So what I was going to suggest we do is kind of walk through how we'd give the bad news with this patient again, and this man would be watching us like a hawk as we walk in the room. He's going to be seeing, and the fact that we're not giving him the bad news right away, he's going to be thinking, uh-oh, something could be up. Because if his biopsy was negative, we would walk in the room and we wouldn't beat around the bush. So we're then going to deliver the bad news in a clear way. We'd ask him, are you ready to hear about the results of the biopsy? Again, he's listening to our tone. Our tone is going to be serious. And then we're going to give it in very small amounts. We're going to say that biopsy showed cancer, and it was surprising to us, but that's what it showed. And then we're going to pause and let him react to that. And he's going to look stunned. And so you have a choice then, right? Are we going to go with his stunnedness, or are we going to go with keep giving information? And I think I would be going with his stunnedness. So I would be acknowledging that. I was stunned too. It's pretty normal to be stunned. We're going to have to figure out how to approach this. And depending on how much emotion he's expressing, we might stay with that for a while. We might ask, would he like to hear a little bit more about what's involved in this? And if he says yes to that, we're going to give him a little bit more information. We're going to make sure he understands it and go back and forth in that way. We might use a wish statement. I wish this wasn't happening to you, and I really did, in this case, really wish it wasn't happening to him. In this case, he was devastated. I think it was pretty obvious to us how he was devastated. And then we had the challenge of how to tell his family, because again, he was coming in by himself. is he going to go? Do we need to call his family? Do we need to bring them in? Are we going to have to meet with him in the next couple of days? And we're going to have to arrange for him to see some other docs. So this is a very complex interaction that a lot of information has to be shared. But again, we're not going to be able to give him a treatise on gastric cancer because first of all, it's going to be overwhelming to him because this news was such a surprise to him.
So Tim, we actually have a question that
Okay.
follows that. And someone asked if there are any studies that have been done about patients harming themselves after they've been given bad news.
There are case reports of people committing suicide after bad news. So again, if you do get a hint that somebody's considering that or they say something, I think I'm just gonna call it quits. You're gonna need to drop everything and stay with that and make a safe plan with them. So I think it is a time when, particularly when people don't know very much and they're just kind of reacting to this, and maybe they have some family history issues that are getting activated, that you want to be very cautious and be aware of that. Again, this is why if you know you're going to be delivering bad news that's really bad, generally you like to have somebody come in with a family member so that they can make sure that they're going to have somebody with them when they go home. This particular man was in by himself, by his own choosing, but still that means that the safety issues are a little bit more daunting. So things to think about in your own practice around this stuff. Bad news is really common in general medical practice, particularly if you include smaller kinds of bad news. Anytime a new diagnosis of any substance is being given, certainly any chronic disease diagnosis. We have trainees or colleagues, again, think about, particularly on the big bad news cases, having some debriefing afterwards. So let's talk about how we did. What do you think went well? What do you think we might have done better? You can ask for feedback. You can always, and if you are observing a junior colleague doing this, perhaps if you're at a teaching hospital, you can always find something that was done well and something that might have been improved. But by unbundling these experiences, you can certainly make people's practice a little bit better and make their awareness of how the things they do well and things they didn't do well might be improved. And then there are some brief articles attached with this. If you haven't read these, they're probably worth pulling and reading. They're actually all very short articles. Tony Back and Bob Arnold and James Tulsky have written about this in one of their OncoTalk manuals. There's the Spikes strategy for six-step strategy, which basically is using Robert Buckman's strategy for delivering bad news. And then a couple of other articles that might be of interest. The wish statements. A lot of people who haven't used wish statements might want to experiment with that. This is a very short article on learning to express when things aren't going as we would wish, so that you can experiment with trying that strategy. And then finally another paper by Tony Back and his colleagues around bad news is in a cancer journal. Really a generalizable task, a generalizable strategy.
And Tim, we actually have quite a few questions here, but we're coming up on on our time, and I actually have questions myself, but I think we're going to have to wait for the podcast that's going to be coming. So let me just look here. Yeah, we have quite a few. How long on average does your conversation usually last? What are the constraints on time?
Well, it depends a little bit on the bad news. I think we're talking 10 minutes, 15 minutes. I mean, usually I think huge in a new bad news discussion, a huge treatise on the disease is probably not going to be all that helpful. I do think meeting again late, in fairly short order where people have had a chance to think about it, react a little bit to it, maybe talk to other folks. Again, another meeting. A big bad news discussion with a family where you're really going into some new terrain. I think those conversations are longer. I try to protect time to do them, have them be at the end of the day, set aside time, because I think trying to cut those short is not, if you've gotten everybody together to do that, I think that's not a good, you want to take full advantage of having all that expertise there, family expertise and colleagues' expertise.
So we have a few questions, and I hate to let them go unanswered. We're right at the 30 mark here, but maybe I could just throw these out to you and see if you can answer them. In your experience, what prevents so many clinicians from following these simple steps?
Well, I think they've never been trained. I think we have our own emotional responses to delivering bad news. I think we're much more comfortable with the information side than the emotion side, and I think that probably is what makes us uncomfortable and perhaps not as skilled as we might otherwise be.
So when you're calling a patient about setting up a meeting and to share with them this bad news, and they say, just tell me on the phone, should you share the information on the phone?
Well, I think that's a tough call. I think if you have that information and you're really on the phone with them and they're really asking you directly, they're going to be listening to the tone of what you're saying. And I think what I would say is I would really rather talk to you face to face. If they really push and really want to know, I will get into the conversation to some degree over the phone because I think it's not fair not to do that. It's too withholding. And of course, if I was in that same conversation on the phone and the news was good, I would of course not withhold it, right? So they're going to know that there's something bad, but they don't really know how bad and how deep. And I really don't think it's wise to get into a huge, deep conversation except on really unusual circumstances around really bad news over the phone.
And then one more, when using empathic statements with patients, some professionals feel you shouldn't use the I word, such as, I know this is stressful to you, because you haven't actually been through it. Well, what is your feeling on that, Tim?
Well, I think you're sort of imagining how they feel, so I guess I would say I, in general, try not to do that, but I don't worry as much as maybe some other people do. I think if you're really feeling with the patient, I think most of the time you're going to be pretty much on the same target as they are, and I think they're going to experience that as empathy, which it is, by the way. So I try not to worry too much about saying it perfectly because that makes me too left-brained all the time, and I'm trying to respond to the emotion. So I do say I can imagine, and then it's my imagination. So they can correct me if I'm wrong.
Mm-hmm. Tim, thank you so much for talking with us about this very, very important topic. And this is really a guideline, in my opinion, for giving unfavorable news in any situation, not just medical and health, but everywhere in life, really, to follow these 6 steps that you outlined. And thank you to everyone who has joined us today. The recording and the PowerPoint will be available on our website shortly, and we're nailing down our webinar for next month, so stay tuned. Tim, thank you again, and thanks to everyone else.
My pleasure.